Hi, I'm Dr. Castanet, and I'm going to explain to you today why people get neck and back pain. It's very simple. Over time, people's spines get compressed as a result of time, gravity, and genetics. I'm going to use a model for this purpose to explain. This is an example of two vertebrae or two bones in the lower spine, the low back. This would be the back of the person here. These are spinous processes. This is a vertebral body. This is another vertebra. This is a disc in between. There's another disc in between. These discs function as cushions between the vertebrae. If I turn it on end so you can see the top, and you can see this in cross-section, the disc is made up of 12 to 25 layers of very tough fibrous connective tissue that's interwoven like a basket, so that some of these fibers are oriented like this, the next layer is oriented like that, the next layer like that, the next layer like that, and so on. And you get 12 to 25 of those layers, and it makes a pretty tough fibrous connective tissue around the perimeter or periphery of the disc. In the center, the consistency is different. It's a little more like crab meat. It's more watery in content. It holds and imbibes water, and when you're upright and loads are compressing your spine, this inner part is pushed outwards against the fibers of the inner disc, and it distributes the stress to the entire spine and the fibers of the disc. Now, I want to make a note that the outer fibers of the disc are innervated with nerve supply, so you perceive feelings in the outer part of the disc. The inner part of the disc, however, does not have a nerve supply. When we're kids, we start to do things, physical activities, loads, things like that, that start to damage first the inner fibers of the disc, but it's not perceptible. So as we acquire degenerative changes to the inner part of the disc as children and as teenagers, we very often we don't perceive it. Later on, as time goes by and these degenerative changes start to migrate to include the outer part of the disc, we perceive the pain. The peak incidence of disc-related pain is probably in the 40s, when we have a peak incidence of disc herniations and bulges, but changes are happening at a younger age as well. What's unfortunate is it's very difficult to know, as a result of our experience with pain, what sort of physical activities provoke pain and which don't. In fact, we're misinformed because of the associations we make as children about what we can do painlessly. And then as we get older, those same activities are no longer painless, and so there's sometimes some cognitive dissonance in a sense, because we think we ought to be able, for example, to sit on the floor, when in fact it caused damage even as a young child, but we didn't perceive that. So there are certain things biomechanically that are very tough on the disc that you have to sort of learn after the fact as you get older, and then try to be respectful of to a reasonable degree. The pain that you have in your back is a function of a balance between the loads you impose on the back that are excessive and inclined to provoke symptoms, and those that are restful and inclined to promote repair of the disc. And it's this balance that is responsible for how we feel at any given time. But getting back to the central issue of why we have neck and back pain, it's because these discs change over time. They degenerate over time. They lose water content. When they lose water content here, they tend to collapse like that. If the outer fibers are damaged, as is so often the case, discs will bulge out where the fibers are the most weak, and they may bulge or herniate out. The discs, or rather the nerves, which are right here on the side, as depicted in this model, can be pinched by discs that are pointing back and hit the nerve, so that if you hit and compress this nerve, you can get numbness, pain, tingling, inflammation of that nerve, and wherever this nerve runs is where you'll perceive the pain. The more it's compressed, in the case of the low back, the further down your buttock, thigh, and leg and foot you may feel the pain. The less it's compressed, the less far or distal in the leg you will perceive the pain. The neck is similar principally in a lot of ways to this. It has discs in between the bones. It has nerves that come out the side. Unlike the low back, it also has a spinal cord in this central canal here. The spinal cord ends just above the lower back or at the upper part of the low back. So the spinal cord is not a relevant factor in the lower back, but otherwise they're very similar. In the neck, if you pinch a nerve, you'll typically feel pain down between the shoulder blades themselves, and down the arm all the way to the hand. But the point is that it's these disc changes that result in eventual compression of the nerve root. What to do in the way of treatment? Well, the most effective way to treat this thing is to take pressure off of the nerve, to improve the status of the disc, to get the bulge to come back or herniation to come back and get off of the nerve root. When we do surgical procedures for these kinds of problems, whether the surgery is a discectomy or surgery for stenosis or a fusion, all these surgical procedures are directed at decompressing tissues. A less common problem is a slip or of the bones, in which case a bone will actually slip forward, not the disc but the bone. That's corrected with fusion and has a very good prognosis. But when it slips, things get compressed also. So there's a decompressing the spine surgically is either the central primary objective or it's a secondary result as a result of surgeries to fuse a slipped spine. In any case, 98% of surgery is done for compression-related issues. There's a very tiny percentage of surgeries that are done for things like tumors, infections, fractures, dislocations, that sort of thing. Slips are a little more percentage, but all those collectively are still seldom the reason for surgery. Surgery is done because of compression on the spine as a result of disc-related changes, and then over the course of time, when discs change and they don't function as effectively as cushions, then the bones start to deform. I'll show you an example of that. This is an example of how bones will deform over time. Here's a normal model here. Here's a deformed model of vertebrae here. From the side they look quite different also. You get spurs, you get lipping, you get enlargement of the joints in the back here. When the bones enlarge, such as in this degenerated model, they grow in every direction, including in the direction of the nerves and in the neck, in the direction of the spinal cord. When the bones grow in those directions, it's often also accompanied by ligamentous enlargement. All of those conspire or combine to make the space for nerves smaller. So compression, again, is the common theme. When we do X-rays or MRI scans, we use all sorts of expressions to describe these things: disc bulge, herniation, extrusion, protrusion. We talk about discs or bony spurs. We talk about facet arthropathy, ligamen flavin, hypertrophy. We talk about lateral recess stenosis, central stenosis, foraminal stenosis. There are a variety of expressions, but they all essentially mean compression of the spine. We've determined then, I've explained how, what the source of back and neck pain is. The appropriate redress for this surgically is to decompress it. Sometimes it's to fuse it as part of the decompression related surgery. But why isn't pre-surgical or non-surgical treatment directed at treating the compression? Well, it's not. It's a lack of imagination. In part, it has to do, unfortunately, with what we get paid to do. We don't get paid to decompress people's spines pre-surgically. That's a mistake. For clinical reasons, that's my central approach to treatment. If I'm treating somebody with neck and back pain almost all of the time I'm going to treat them with a decompressive approach to treatment. The way that works is I place them on their back, I put them on a table that's very comfortable, I secure their anatomy to the table. The table gently separates these vertebrae like this. I'm exaggerating to make the point, but this is what would happen. It would slowly pull apart the vertebrae. That gets more water, oxygen, and nutrients into the disc between the vertebrae. That reduces the compressive load on the bones and on the disc. It also opens up and makes more space for the nerve roots. It encourages or permits the disc to go back in the direction that it would typically want to, meaning a bulge or herniation can recede somewhat and get off of the nerve. Discs have some regenerative potential. It's not something that is appreciated by most clinicians, but if you look at the research literature, they've done plenty of animal studies, and they have determined that very predictably discs can be influenced favorably by distracting them to get more water, oxygen, and nutrients in there. That it creates a better environment in the disc for the cells that live in the disc. The cells can then divide and make more cells, and they have quantified that those cells then make more molecules to repair the disc. So there is some regenerative potential in discs, and if you exploit that, you get better clinical outcomes with patients and in treating patients, and there's less need for things like injections and surgical treatment. These are facts that are little known or appreciated and not exploited to the betterment of the treatment of neck and back problems. I've been doing this treatment for the last 9 years after 18 years in an orthopedic physical medicine and physical therapy environment. My treatment outcomes are vastly better than they were when we just did exercises and rehabilitation. This is a more direct approach to the cause, to improving and essentially curing the cause. I don't want to say cure, but to improving the status of the disc and addressing the cause of neck and back pain. You will get better from this treatment, in all likelihood better than you will from other treatments. It's a mistake to just spend your time treating patients, teaching them exercises and core strengthening. That makes no sense. Core strengthening makes sense, but not as the direct redress for the problem and cause of neck and back pain, which is this slow, compressive, lifetime process. When people get better, they generally stay better for many months to several years. I've treated people 8-9 years ago who still refer other patients to me, and when I inquire how they're doing, they're very often still doing better. There are other patients that I will see more frequently. They may come back to me for a few treatments here and there every many months to several years. If people don't get better and stay better, and this is a very small percentage, I will send them on to injections and sometimes surgery. But in terms of pre-surgical, non-surgical treatment, this spinal decompression treatment is the most effective. It's the most rational, the most logical, the most intuitive, and the most effective treatment in my clinical experience of 28 years. I've also spent 4 years in neurosurgery and a neurosurgical practice learning surgical indications of procedures. So there is a time for surgery. I have good relationships with pain management also, because that's sometimes appropriate. But in terms of pre-surgical, non-surgical treatment, spinal decompression is the way to go for most people. If you do it, you'll get better and you'll stay better longer. It's a treatment you should do intermittently when you need to during the course of your lifetime. Back and spinal problems are not something you treat once in your lifetime, whether it's surgically or injections or otherwise. Very often people will need intermittent treatment. So the question is, how are you going to do that? How are you going to manage these intermittent back and neck problems? The most effective way is not through a series of surgeries or a series of injections for the rest of your life, but rather a series of intermittent decompression treatments and injections and surgery as an occasional adjunct to that. If I can help you with your problem, I'm in Decatur, Georgia. My name is Dr. Castanet, and our phone number is 404-558-4015. Thanks very much. Bye-bye.